Welcome you
Hi,
back.
morning.
Welcome you back to India Live 2020.
Thanks.
So we are all waiting because you told me that you have an
India Live for the
anomalous vessel
invitation.
which you're going to be telecasting, and we have a very erudite panel comprising titans like Dr. Samin Sharma, Dr. Gurpreet Sandhu, Dr. Subhash Chandra Praveer, and Sandeep Bansal all here with a lot of eager beavers, even at the fag end of the course, who are still around, you know, so to see something dramatic that you will do.
Okay, thanks for the invitation. So before going ahead, let me introduce my team. I am there with Dr. Basan, assistant professor with me. Dr. Ganesh is there, the post-DM fellow with me. And Dr. Pruthi is there. And other than this, I do have the team of OCT and IVS people, Puneet and Prince, and the nursing staff. And now may I request Dr. Pruthi to go ahead for the presentation of the case.
Good afternoon, everyone. Today we're doing she is a 60-year-old normotensive non-diabetic female. She has presented with class 3 angina since 6 months. Clinical examination was unremarkable. ECG showed left bundle branch block with normal PR interval. Next, please. This is the ECG which shows left bundle branch block with normal PR interval. Next. 2D echo showed normal LV function, and the yellow pointers are towards anomalous coronary artery. 6 weeks back, she underwent coronary angiogram of right coronary system, which showed proximal to mid diffuse disease, and she underwent PTCA to RCA with 4 into 38 mm drug-eluting stent. Next. So this is the coronary angiogram of left coronary system, which shows a significant disease in the left main and diffuse disease in the left anterior descending artery proximal to mid, and disease in the proximal part of left circumflex artery. Next. So our plan is to do PTCI to left main and LAD with PCI optimization by intravascular imaging.
Okay, so these are the few points to be discussed about. Course of left main after its origin, anomalous left main from the RCA, how rare it is, and which guide to cannulate the left coronary artery. So any comment or suggestion from the panel?
So we know that you told me that you've had the patient undergo a CT angio. So you might as well tell us if it is an interarterial left main or not. So we have some privileged insider information.
Okay, fine. So next slide, please. Next slide, please. So here is the course of the left main, which is retroaortic after getting originated from the right coronary sinus, which is evident on the angiography. And if you see the apical 5-chamber view on the echo, there is a straight line which is again suggestive of the retroaortic course of the left main. CT has also shown a left main which is going between the aorta and the LA, which is suggestive of left main having a retroaortic course instead of it's an interarterial septal or anterior femoral course. So these are the 4 types of course, out of which the retroaortic course is the one which is there with this particular patient. Next slide, please. Reviewing the literature, we found that this type of retroaortic course of the left main is around 0.17% in the angiographic series. And regarding the PCI of retroaortic course and the left main, there are only 5 case reports been published in the literature till date, out of which the 1 case is ours, which we got published in 2011 in World Journal of Cardiology. And recently, the particular patient had in-stent restenosis of cipher stent after 14 years, for which we did the OCT guided again stenting on the same patient, and which got published in Journal of Invasive Cardiology. Next slide, please. So this is the published case of ours. This is after having an in-stent restenosis of the cipher stent after 11 years, and we did the OCT guided stenting on this particular case. Next. And this is the old case where when I did put the cipher stent across the proximal and the distal LAD. And here I just want to note about that I did use ECR guide around 11 years back, and in the previous slide, please. when recently I did the case with the OCT, it was the AL1 guide which I used to cannulate the left coronary artery. Next slide, please. Next one. And this is our experience of anomalous LCX arising from the RCA and the PCI. Total 13 cases has been done in the department by me and my team. And most of the time I have used AR1 and JR 3.5 or 4. First slide. First slide. So this is about the case. I did the check angiogram, and initially I did took AL16F guide. RCA stent is fine. Next.
Can we see the angiogram?
Turn the AL1 guide to Hannes. This is the today's angiogram. So AL1 guide, there was a difficulty in cannulating the anomalous left main. Next slide, please. So I was trying to cannulate the left main, but then there was a difficulty. Next. So this is the AL1, different shape of the wire, not able to pass through the left main. Next. 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 So then ultimately we change it to the AR1 and then able to pass a choice PT wire, and this is the second BMW wire across it. Next. So, next please. So this is what, next please. So here I was in the proximal LAD and also LCX. Next. Next. So we could pass the wire across the LAD and also the LCX. LAD is tightly diseased, which was dilated with 2.5 15 millimeter balloon. Next. This is the balloon dilatation of the LAD, and again at the left main as well. Next. Next. Here I had no difficulty in passing the OCT catheter, and also I was possibly because of intermingling on the two wire of the LAD and LCX. So next.
So your guide remained stable during all these?
So I did put, patient is stable, 166 is the blood pressure just now. Heart rate is around, how much heart rate? It's 80 or 90?
Yeah, 90.
Wrongly, 95 is the heart rate. Patient is stable. Here I have put, without doing the imaging, 2.7538 across the LAD. Next. Next. So this is the LAD stent in 2.7538, Giants stent. Next please. Good result. Distally there is some haziness. Let me see with the imaging later on. Next. Dilated. Next. Dilated the LCX as well with 2.5 millimeter balloon. Next. Next. And here, after putting the stent across the ostial LCX 2.7528 Giants, I had done the OCT. Can you show the OCT across? So now I had done the OCT across the left main to the left circumflex. As they were difficult in pushing the catheter across the left system, I removed one wire across the LAD. Can be very well pushed later on. And let's have a look on the OCT imaging. Can you see the OCT imaging? So there is some calcification.
Nothing that we can see.
No. Looks pretty good.
Yeah, it looks all right. There's some calcium, yeah, that's okay. Some dissection.
And here is some ulceration.
Or plaque rupture or your balloon injury, maybe.
Yeah.
Plaque rupture, yes.
It's a dissection.
You're right.
Dissection.
And what's the size of the left main? It's a 4. It's a 4.10 is the size of the left main. Can you measure it? Iliocranial. So here now, we are live now for any suggestion or comment. So this is what, if you see there is some dye staining in the left main, must be because of the ulcerative plaque over there. The size of the left main is around 4. And let me go ahead and put a 4 millimeter stent across. Is it okay?
Yeah, I think so, because it appears to be a straight road map, and you already have to have figured out what you have to do, so you can, if your contrast is staining in the left main, go ahead and fix that. Or if you would like to do the distal first, that's also
So
okay
let
with
me
us.
go ahead with a 418,
That makes sense.
Yeah, both options are
Both
fine.
options are good.
Sorry. It's 4.
Put one stent or put one
So I'm
stent in
going
the
ahead
circ
with
and one in the left
423
main.
giants.
So it's too
Yeah,
long to
I
be
have
treated
already
with
put
just
the
one
two stent
stent in any
across.
case, sir. And there's a difference in
48.
sizes.
Exactly.
There's a disparity in the diameters.
And the circ has a very nice proximal landing zone
Absolutely.
before the bifurcation. I'd put one
You
stent
don't
in
have
the
to
circ.
compromise the
Exactly.
LED.
And then a bigger one more proximal in the
So
left main.
we think you should fix the circumflex and left main separately. But
Yep.
No, we have already fixed the circumflex AP cordon. Can you go to the previous view?
oh, you already fixed
We
it.
have already fixed put a stand 2.75.
You're one step ahead of us.
28
So then go ahead and fix the left main.
So it's only the left man which is remaining.
It looks beautiful.
Yeah, it looks very
I have to fix
nice.
the left man, that's right.
Yeah, go
Both
ahead and
have been
fix the left
fixed.
main.
23. 423.
इसी व्यू में
Yes, circ may require some post dilatation in the
Touching
middle
up,
portion.
yeah.
Yep.
But rest looking good, so put a stent in the left main and then post dilate. Ostium actually, ostia of both the
So
vessels.
the plan is to go ahead
Look
for the
good.
imaging after putting a stand across the left main.
He's lucky.
Actually, could you use a
I think this
28?
is okay.
You could use 28 millimeter. Remember, still there is a mild disease, little distal, little proximal.
But he's seen an OCT, and he probably thinks that there is a
28,
normal
428,
segment there.
428. 28, 28.
It's a normal segment there.
Yeah.
It's normal
Yeah,
segment.
this is.
Cine. So this is okay, normal segment. Distally,
No, but Dr. Sharma has a point that there is some plaque burden distal to where your stent is, but that's okay.
Yeah, would have been nice to cover the whole
The
thing,
whole
but,
thing,
but even this should be pretty good.
12, 12, 12.
Eleocranial, 13, 13, 14, 14, 15, 15, negative. So she is okay, hemodynamically stable.
What stents are these?
So it's a Giants 4 into 23 across the left main and also in the LED and left circumflex. So this is the result. So it has to be post dilated. Let me see in the imaging what size of the balloon is required for, or do you feel like 4.5 is fine to go at 4? 4.5 balloon.
The left main stent looks a little bit strange with the dye
Yeah,
staining.
it's a, maybe that's where there was a large ulcer crater as
Yeah.
well, and that's maybe.
I would post dilate the circumflex and then do some imaging of the left main.
Yeah, but till CT angios were freely available, we used to all struggle with the dot and eye method in trying to define the course of the anomalous left from the right. But I guess that issue has been taken away once CT angio is freely available.
Otherwise, you used to put a catheter into the
Pulmonary artery.
and take a multiple views, and so all has become theoretical now.
That's right. Actually, we have demonstrated the anomalous LCX in the echo as well. A straight line across the LVOT in the apical four-chamber view is another thing to look for.
So good, you can probably
Anomalous,
follow up with the velocities on
coronary.
echo
So
rather
we
than
are-
doing imaging later.
12, 15, 15, negative. So here we are with 4.5 millimeter balloon across the left main stent. 15, 15, negative. Stent boost. So I'm just confirming the balloon position in the stent boost. So this is fine. 15, 15, 15, 15. Negative. So it's the NTG which we are giving. And let's see the result. So this is what after the post dilatation, and let's go for the imaging now across left main to LCS, OC.
So we would really like to know what's happening proximal to the left main stent, in that area.
Yeah.
So maybe imaging can tell us.
That will be clarified in the OCT imaging.
Yeah.
That's right. Maybe another view, AP caudal. So this is what the proximally it is
Yeah, this
fine.
is. But let's get the OCT catheter in and see what we.
Yeah, it looks more reassuring in
Yeah,
this view.
That's right.
We're feeling better.
But Dr. Sharma still wants that circumflex post-dilated.
It looks like in the segment, middle segment, slightly
Underdone.
angiographically.
Yes.
तो ये टिप बताना वायर का टिप. You are able to see? हाँ ठीक है. So we are partially across the LCX. Distally there is no margin, so not able to push the catheter across. Let's see how the LCX and left main is looking like in the OCT. That's why. So display the OCT.
Yeah, yeah. Can- Can we see the OCT full screen? It will be.
Fully screen OCT, please.
Thank you.
So this is about the OCT across the LCX. It's a 2.75 I had deployed across. And there is no red colored structs across the LCX. But let's have a look on the how much diameter it is. proximally, yes, there is need for the post dilatation. And this is about the left main. At 9 o'clock, you can see some plaque is there. Calcification at 9 o'clock.
That's
And
right.
this is the left main
Non-critical.
stent getting
Well opposed.
post-dilated with 4.5 millimeter balloon, well opposed.
We actually need to see the area proximal to the
Increase
stent,
10 instead of.
Which is not recorded.
which is probably
But
not
then I have to
recorded.
take another run across. Let me have a look.
Yeah.
So take another run for the proximal part of the stent. Okay, I'm ready. So fully screen OCT to show the run across the left main stent. So it's a well opposed stent across the left main, which was dilated with 4.5 millimeter balloon.
Looks okay.
And this is the proximal segment, which is fine.
Looking good, yeah.
Yeah, that was, I think there
Here's
was a
a
little
catheter tip.
ellipticity of that area, and that is what was in orthogonal views was showing up differently.
What about the LCX? What's the size of the LCX? Can you run it? Three millimeter NC, 3 millimeter NC. So it's around 3 millimeter the left circumflex size is. So let me dilate it with 3 millimeter balloon, NC balloon, followed by OCT of the LAD,
Yeah.
and then appropriate post dilatation of it as well.
But you've made an anomalous vessel look very, very easy.
Absolutely.
Thanks.
Yeah, looks brand new.
Anomalously brand new. Huh?
Where is the stent across? Can you put the stent boost across? So we are okay. Let's go ahead. 12, 15, negative. 15, 15, negative. थोड़ा आ रहे हो देना, आ रहे हो.
So I'm really intrigued. I would like to ask Dr. Sandhu and Dr. Sharma that in view of things like the complete trial, if this patient had come to you with an inferior myocardial infarction, you would have fixed the right, would you have taken on the anomalous left main, LAD and circumflex in the same sitting?
Sorry. We'll try to stage it with a concept of 3 to 4 weeks later. I know with the complete, whether you did within few days, but not at the same time. Same hospital admission or 1 day or 3 weeks didn't make a difference. But usually, from strategy point of view and there are other regulatory insurance issues, and so we bring those patients back after 1 month.
Yeah, in our case, we would treat the acute lesion right away.
Yep.
And with all the remaining lesions, if they are critically tight, we'll probably do it in the same hospitalization, which might even be the next day. But otherwise, like Dr. Sharma said, we will bring them back after a few weeks and then treat those.
Dr. Subhash?
I quite agree with it. In this particular case, this is the perfect approach because those lesions were not critical.
Yeah. Praveer?
One can always.
Sandeep? Everybody agrees, huh? Yeah. Okay. No, I was just in view of complete trial, would you like to take on everything together? And 2 minutes. We have 2 minutes to go, so if you're showing us some nice images, otherwise we really value your expertise and finding such a case.
Maybe I can go ahead. Now I have to only do is to have a wiring of the LED imaging and then appropriate dilatation. If you want, for the time I can have a look on the LCIs by doing the OCT in next 2 minutes.
Okay.
OCT.
We want to do imaging of the LED now.
Yeah.
OCT.
L6.
L6. So let me go ahead and do the imaging after post dilatation of the left circumflex.
It's an unfair question, but how much of contrast has been used in all these OCT runs?
So how much contrast have we used?
And suppose this patient had a creatinine of 2.8 or 3, would you have done it with dextran as you have shown us in the past?
Her
150 ml.
Her creatinine is 0.9 milligram%, so we are comfortable with, that's
150
one thing. And amount of contrast, how much I have used? So it's a 150 by now, and 10 more for the left circumflex. Is it okay?
You need to be a magician to be able to manage so many OCT runs in just 150 mils of contrast. I mean, I find that a little hard to accept, but all the same, we believe you.
15 per.
So I didn't count it, frankly speaking. Maybe somewhat on the higher side in case you are telling about. But then creatinine is fine. We are taken care of the hydration. She is not a diabetic, and therefore there is not a concern about, say, contrast-induced nephropathy. So can you show the OCT images of the left circumflex, big screen? So this is the OCT imaging, well-opposed stent with a 3 millimeter balloon dilatation across it. Just stop. Any further comment about?
No, it looks great. Excellent case demonstration with the imaging guided, fantastic case.
Thank you very much. Thanks India Live for the invitation.